Good evening. Welcome to SpectraCell's Thursday night webinar program. Tonight we continue our series on the gastrointestinal tract with how nutrients can impact the gastrointestinal autoimmune connection. A copy of tonight's slides and additional resource materials are available for download in the resource list box on the left. There is also a Q&A box should you have any questions during the webinar. An on-demand version of the webcast will be available tomorrow and can be accessed using the same link you used to register. At this time, I would like to welcome back Dr. Arland Hill.
Thank you, Jessica, and good evening, everyone. I want to welcome you to the presentation. I feel like this is a very interesting presentation. I feel like it's one that most of us are probably interested in. Obviously, it's hard to practice and function in the world of functional medicine without having an interest in gastrointestinal function. But as an extension of that, and I think that an area that's certainly getting more and more attention is autoimmunity. And I think most of us probably at this point recognize that there is certainly a connection between these two areas. But I think it's also important to note all the other factors that begin to play into this, and then also looking at how nutrition begins to have a role here as well. Because certainly what's recognized is that the modulation effect of nutrition in terms of autoimmunity is fairly profound. So with that said, let's go ahead and look at what we're going to be talking about tonight. I want to give you this idea of this triad of dysfunction of autoimmunity, and this is even something that, from the standpoint of communicating the message of autoimmunity to patients, this is a very easy to understand idea that can be communicated to the patient to help them be able to understand why you're addressing each component or how you're addressing each component of your autoimmunity. And I think for us as practitioners, it helps keeps us focused to make sure that we're addressing each aspect of what might be potentiating that autoimmune response. Certainly, we're going to look at the role of nutrients in each one of these three phases. And then really when you come right down to autoimmunity, I mean, you're really talking about the ability of the immune system to self-regulate itself. And if we lose that ability, that's in turn when tissues start to become recognized as a problem by the immune system. So if we can intervene to be able to make sure that there's this idea of self-tolerance, that the immune system hasn't started to turn on itself, that we're getting these adequate chemical messengers between the various aspects of the immune system, and also certainly between not just the immune system, but also between the genes and the environment and how that interrelates to the immune system, then we can have a better opportunity to modulate the self-tolerance impact from the immune system. And then we're going to look at some novel markers. There are some markers within the micronutrient assessment that are fairly unique to that test. And I want to point out how to utilize those. I want to give you some background in terms of what these are really indicating, and talk about how they can be utilized and how they may be representative, and maybe to some degree predictive, and maybe even diagnostic of an autoimmune presentation. And we'll talk about those as we move forward here. So with that said, let me just give you a little quick background and put this in perspective, because I don't want to belabor our conversation with a lot of statistics here, but I think it's important to look at a couple of things as it relates to autoimmunity, just to put in perspective how big of a concern this is. Again, most of us will certainly agree to the fact that many of the patients that walk through the door, the larger percentage, don't have ideal gastrointestinal health, and there's a number of factors that are associated with that. But when you look at that fact alone, that also suggests that these individuals are at a higher risk for autoimmunity, and certainly the statistics bear that out. If you look at just since World War II, there's been a significant increase in autoimmunity. You have at this point, and there's certainly a laundry list of conditions that are classified as autoimmune. And probably the thing that was most profound to me in looking at some of this statistical information is that autoimmune conditions are considered one of the top 10 leading causes of death in females in the United States. So that underscores its significance right there. And also what's that I didn't put in here, but what is also worth mentioning is that when you look at the top 10 medications that are when you look at the top 10 medications that are prescribed on an annual basis in the United States, and you look at the trend over the last 5 to 10 years, you'll see that the autoimmune drugs have become more prevalent in that top 10 list, and they make up a reasonable contribution to that list. So that's certainly worth noting as well. From a population, from a percentage standpoint, you're looking at somewhere, according to NIH statistics on this, you're looking at somewhere around about 13% of the population, maybe a little more, are going to have an autoimmune condition here. But what's not taken into consideration for this is there were only 24 when these numbers were developed. There were only 24 diseases that were considered in this listing. And the other fact of this that you want to note that really, if it were considered, would have pushed these numbers to a much higher degree, is that this is looking at a named condition to the point where there's already an ingrained state of dysfunction. This is not taking into consideration those individuals that have the predictive antibodies and that have not developed into that full-blown damage of tissues to the point of a named disease state yet. They're just showing a trend in that direction. So if those were considered, these numbers would be much higher. So with that said, and with that little bit of background, let's look at autoimmunity and start to begin to think about the complexity associated with it. One of the things that you have to really begin to appreciate with autoimmune conditions, and it doesn't take long after going through some of the literature on this, that there's not going to be one singular cause for an autoimmune condition. There has to be a myriad of things that take place, and then even within two individuals that have the same named autoimmune condition, the environmental stimuli that may have been a factor leading to the progression of that disease state may not necessarily be the same. So it does add a level of complexity. So there's not this sort of magic bullet approach to dealing with the autoimmune condition, as there's not with nearly any condition. But I think autoimmunity, the level of complexity associated with them and the number of factors that have to be considered continues. There's probably more that you have to factor in with that condition than many of the others that we may see on a day-to-day basis. Now, when we look at the triad here, this is a really, and this is again an illustration that I like to use with my patients because they can begin to sort of see where the lab results fit in, and we can make the connections for them to ultimately address the condition that they're presenting with or the symptoms they're presenting with. So you have to have some type of genetic predisposition here, but as we can all appreciate, genetics it's not a sentence to say that you're going to end up with a particular condition. It just says that there's a greater predisposition that you have the opportunity to develop that condition. But it's not definitive. What you also have to note on this is that a lot of times there's going to be an environmental factor, or not even a lot of times, all the time there's going to be an environmental factor that opens the door to that autoimmunity. And typically what's happening here is there's a disruption in immune function that has to take place. And when you combine these two things together, when you look at genetics and the environmental factors, we get this idea of what's known as epigenetics. So it's really not just about the genes or just about the environmental trigger. It's about how do the genes that a person has as a part of their genome interact with the environment that they have around them. And maybe that environment, that environmental factor, you have to think about that as not just a toxicant in the environment, but maybe the foods that they're consuming. And yes, there may be toxins associated with that, but it may be the food that they're consuming. It may be something that they're applying to their body. It may be something that's isolated, or it can be isolated within the home that they're in. So there's any number of environmental factors that could play a role here. And then the last of the three factors that has to be considered is gut dysbiosis. So again, when we're looking at these factors and talking about the link into or the link between the gastrointestinal tract and autoimmunity, the dysbiotic state is really underscoring that progression towards autoimmune presentations. Now, as we go into a little more detail on each one of these, what I want to do through the presentation tonight is expound on each one of these and begin to talk about where nutrition fits into this. And the idea that I want you to walk away with tonight is to have a working plan so that when you order a micronutrient report on a patient with an autoimmune condition, you can begin to immediately go in and look at that triangle and begin to fill in gaps and make notes of where individual nutrients would begin to have a role at and how to take action. So when we talk about genetics and the interaction of the genetics with the environment or epigenetics here, there's a couple of things. We look at the HLA, or what we also refer to as our human leukocyte antigens, and we know that there are several of those that are correlated with specific autoimmune conditions. Methylation we talk about from a lot of different perspectives, but in terms of how does that methylation act as a genetic, how is the genetic relationship of methylation associated with the environmental trigger? And then looking at the list of environmental triggers, again, this can be a very long list, and essentially, in a nutshell, what this comes down to is it's anything that the immune system recognizes as being problematic that it's going to have to deal with that it otherwise shouldn't, or otherwise that it should be able to pretty well deal with and eradicate from the body, or otherwise it's going to act as a trigger. And then gut dysbiosis, and another way of thinking about gut dysbiosis is just, there's a lot of different terms we could think about in terms of, or a lot of different terminology that we could consider here. We can talk about it in relation to gut dysbiosis. We can use the terminology leaky gut. We can use maybe a more scientific explanation and talk about it in terms of intestinal hyperpermeability. It really all comes down to this interaction between the microbiota of the gastrointestinal tract and how they're going to support these enterocytes, those cells that line the gastrointestinal lining, and how they modulate the immune responses, and also how they support the replication of those cells to maintain that barrier lining of the gut so that we don't progress towards a leaky gut presentation or towards an intestinal hyperpermeability presentation. Now, I mentioned that there are a couple of the human leukocyte antigens that we want to make mention of here. These are some of the more common ones that are often talked about with genetic testing. With celiac disease, the human leukocyte antigen is one that's certainly recognized, or the HLA-DQ is the one that's probably most recognized here. And there are different variants of that. And what you want to think about with this is that what's happening here is that a genetic profile where you have an HLA-DQ gene that increases reactivity or increases your predisposition to celiac, literally what that gene is telling your immune system is to be more reactive against, in the case of celiac, against gluten. So there is an increased responsiveness to gluten by the immune system as a result of that HLA-DQ, and again, depending on what the secondary fraction is, there's going to be a more pronounced response against gluten. The immune system is genetically has an upregulated response towards gluten, so therefore that individual is going to have a greater likelihood of reactivity towards that, and hence that's why you see such a profound number here of 95% in that case. And then, of course, you have other autoimmune conditions that also have these HLA recognitions as well. HLA-B27 being another very common one that's looked at. I wanted to put in this just a schematic of what you're actually talking about here with these HLAs and where you think about these things at. These are going to be located on chromosome 6. You've got your short arm, your long arm of the chromosomes, also known as your P and your Q arms here. Your short arm would be your P arm. But this is essentially where you're going to find those various leukocyte antigens, or human leukocyte antigens. So if you're doing any of the larger panels looking at genetics and you're trying to figure out, well, does someone have an association, chromosome 6 is where you're going to want to look for some of these things at. Now, these epigenetic associations and looking at is there a basis behind these things actually progressing the presentation of autoimmunity, and indeed there is. And you can see from this the associated epigenetic marks and dynamic changes control the dysregulated immune system. So really what that's telling you is that this interaction between the genes and the environment is what's governing how the immune system is going to react to the various things that it sees on a day-to-day basis, whether it is going to have a greater predisposition to react towards what it perceives as an antigen, or whether it's going to avoid that antigen, that foreign substance, and not have a reaction towards it. And also you'll see in this is that there's a determination towards the development of that clinical phenotype, so that physical expression of how that autoimmune response is going to play out. It goes beyond just the genotype, just knowing what the genes are. The genes in and of themselves aren't going to elicit the immune response by themselves. There has to be a greater combination of factors that all begin to integrate together to promote this response. Now, looking at how the genes interact with the environment here, I've mentioned a couple of these, and you'll see that I just really want to put this in here. So one, you could see that, again, there is a fairly solid body of evidence out there linking the two together between genes and environment and the whole study of epigenetics. But again, looking at some of the things that are potential triggers here, and looking at whether you're talking about an infection or whether you're talking about hormones. And from the standpoint of hormones, you could even probably look at a subset of that and think about the idea of xenobiotics, so maybe some of these estrogen mimickers out there, but even the hormones themselves, and certainly some of the drugs, looking at these foreign substances, and then the idea of pollutants and looking at how vast of an increase these have become in our environment with the increase in industrialization. And we see that toxic burden in the environment continues to grow, and as that continues to happen, you're going to see that the progression of autoimmune diseases continues to progress with that. There's a pretty well noted correlation here, which I think all of us can appreciate, that the nutritional status of the average population continues to decrease, the toxic burden of the average population continues to increase, and those things set up the perfect storm for the autoimmunity to begin to manifest itself, and that's indeed what we see on a day-to-day basis. Now, moving into the DNA methylation here, you can see that DNA methylation has been correlated with a number of autoimmune conditions. It's going to be relevant to that epigenetic response, and in terms of how the genetics, not only do we produce the right genes as a result of DNA methylation, but then in terms of looking at the production of methyl groups to interact with the DNA once these genes have been produced, to interact with the DNA and to more or less, maybe from a more simplistic mindset, do we turn the gene off to react to the environmental trigger, or does the gene stay inactive and not react to the environmental trigger? So the ability to methylate, you can think about it from a couple of different perspectives. Think about it as the sort of yes-no checkbox of it's going to react or no, it's not going to react, whether or not you methylate. And then also, are you coding for the right genes that are going to produce ultimately the right proteins that are going to be easily recognizable as self by the immune system, or is there going to be a aberrant presentation there that the immune system might recognize that tissue as problematic and want to develop a response against that? So we do see it in multiple autoimmune conditions. Some of the nutrients, the ones that are linked to DNA methylation here, there's the common ones of B12 and folate. Those are probably the two most recognized in this group, but those are by no means the only ones here. The methionine, the betaine, the trimethylglycine, choline, these are in, but you'll also see nutrients in these cycles as well. Your B2, your B6, your zinc, your magnesium. These are equally going to have a role. Serine, cysteine, these are going to all be considerations as well. And certainly when you look at that list of nutrients that has the ability to play a role in DNA methylation, you're going to need some ability to be able to differentiate which nutrients are really factors to consider here and which ones don't need to be considered. We certainly want to be able to maintain a balance between these nutrients so that the methylation process can be carried out consistently and effectively. Just as an overview, looking at where some of these nutrients fit in, the highlighted regions, the 5-methyl tetrahydrofolate, the B12 as a part of the methionine synthetase enzyme here, and then ultimately your methionine. And really, again, what you're looking to try to do is twofold here. You're looking to make sure you're producing the right base pair so that you can code for the right type of protein or right amino acid to build that correct structural protein. But then you're also looking at having the methyl groups so that these methyl groups can interact with that DNA to modulate how the environment or how the environmental trigger interacts with the genes. Does it have a profound response, or do the genes not react to it? And again, it's ultimately that epigenetic response that we're talking about here. Very interesting outcome in this particular study, and I think this is I like having evidence like this because it always reminds us as clinicians that you don't want to overdo it. You don't want to forget about the nutrient interactions and how these nutrients all relate to each other and how they work together in biochemical pathways. And certainly what is appreciated from this is that definitely if someone has a variant in MTHFR in that particular enzyme, that can easily be bypassed with a methylfolate, with a 5-methyl tetrahydrofolate form of folate. However, there is definitely evidence, which I think in time many of us see, that you can over-methylate someone too. So, as a result of that, we see patients popping up with symptoms. Maybe anxiety is a presentation of that, or maybe you see it more from a laboratory standpoint, where you ultimately look at depleting nutrients such as B12, or you end up with a presentation such as a megaloblastic anemia. So we don't want to forget the concept of nutrient-nutrient interactions here, and we want to make sure that we're balancing these nutrients as we're bringing them up and not trading out one deficiency for another, because as I mentioned with B12 and folate, those are two nutrients that we always want to keep in balance with each other. Certainly you're looking at and I'll go back to the idea of the megaloblastic anemia, there's large evidence to show that, and it definitely, many of us have probably experienced this clinically, that if you supplement folate too aggressively, you will deplete that B12, and the presentation on the red blood cells, as far as the size of that red blood cell, doesn't change. So I think we've probably made that mistake. So just really saying all that to say, keep in mind that you can over-supplement the folate even with someone who has an MTHFR gene variant here. So want to keep that balance as you move forward with the patient. Now, the laboratory marker that is most directly correlated to a variant in MTHFR, and the one that the lab marker we probably think about most directly associated with the ability to methylate, is going to be homocysteine. Homocysteine is not in any way a perfect marker, but it's a very good marker. And you can see homocysteine is pretty well appreciated for its ability to damage a lot of different tissues when that amino acid becomes in excess. And interesting is that it's not going to be just your soft tissues like your cardiovascular tissue. You're looking at a pretty large list here. You're looking at cardiovascular tissue, the lining of the endothelium. You're looking at neurological tissue. You would be talking also about cartilage, bone, elevation in greater predisposition towards osteoporosis. There's a link between elevations in homocysteine and osteoporosis. So you're looking at both hard and soft tissues throughout the body. So it's a pretty long list of what can succumb to the effects of homocysteine. But you can see that what happens is as homocysteine increases, it increases the inflammatory response, and you start to modify and damage these proteins. And as these proteins are damaged, they become what's recognized as a neoantigen. So they're a new antigen that the immune system has got to figure out how to deal with. Does it have a response to it? Does it not have a response to it? And homocysteine is just increasing that list of these antigens that the immune system has to make consideration for. And at some point, the immune system, especially when you've got someone who's in a more nutrient-depleted state, that list, even as it's growing, has a tipping point much earlier than if that patient had an ideal nutrient status. So homocysteine certainly you want to look at here. Some of the recognized environmental triggers that we often consider, some of the ones that are definitively recognized here, aluminum hydroxide, that one's had a long list, and we can recognize that one. Aluminum, we don't have biochemical roles for aluminum, so we certainly can recognize that one as a toxicant. Some of your medical silicones, so for example, what you might find in breast implants, these have been associated with a long list of conditions as well. And certainly it makes sense that these things, especially if there's any type of leakage of those implants, that it could act as a foreign material in the body and that the immune system would develop a response against that. The researcher who originally started looking at this, Schoenfeld, if you go to look up any of this, you'll find it under Schoenfeld syndrome, and you may also find it under autoimmune syndrome induced by adjuvants. And that induced by adjuvants really just underscores the fact that there's a long list of things here that could be recognized as foreign to the immune system for which it could be reactive against. Smoking, RA, there's a correlation there. The production of these anti-citrullonated protein antibodies, that is one of the more common markers now we recognize used, not just rheumatoid factor anymore. We've sort of we still use that, but we have other ones to make considerations for as well. And just to the point of how this process begins to play out, I wanted to go into a little bit more detail on the anti-citrullonated protein antibodies and actually what you're talking about here. And really, this citrullination process is looking at the conversion of the amino acid arginine over to citrulline. And when you do that, citrulline is not one of the 20 amino acids that are coded for in our DNA. So when that amino acid ends up in a protein, there's actually going to be a modification of that strand of proteins, and the protein structure itself becomes different. Now, you'll have to appreciate that when these proteins start folding on themselves and they're making up what we classify as these quaternary structures, these larger protein structures, that folding and linkage process becomes modified when you've inserted in citrulline versus inserting in arginine. And as a result of that, you've got a new protein that the immune system has to make consideration for, and it recognizes this as a foreign substance, and it develops that immune response against it. This is also seen in cases of autism, where you look at what's known as myelin basic protein. Myelin basic protein is another one of these citrullonated proteins, so another one worth consideration there. Another area where we're seeing a correlation with the environmental exposure, thyroid. I think a lot of us will certainly see this in our practice, see autoimmune thyroid conditions, maybe to the progression of Hashimoto's. But what's very interesting in this is that you'll notice that the main considerations as noted by this study as to what allows for progression to autoimmunity of the thyroid is nutritive factors and environmental pollutants by metals and chemicals. So this one's even very specific. And if you just think about on a daily basis, if you live in especially in a metropolitan area, you're going to run into heavy metals. And it doesn't even necessarily have to be a metropolitan area. And then when you look at the food supply and the consumption of herbicides and pesticides that get applied to the foods, they're so ubiquitous in standard agricultural practices that if you're not eating foods free of these things, then you have to consider that you're getting some undue burden of these. And they're again triggers. When you look at genetics, genetics is such a complex topic, and there's so many things that have to be considered. And again, I like the fact that, in the slide we're differentiating just if you have a genotype, then a lot of times patients like to think in terms of simple genetics. They like to think if you have the genotype, then you're going to end up with the disease state. And we as practitioners know that there's far more complexity than that, and that's absolutely not the case. And a lot of times why maybe we don't even want to open that conversation with patients, because we don't want to get them locked into thinking that they're going to develop these disease states. But what is also recognizable is that you can take that individual with a genotype, or 4 individuals with the same genotype as illustrated here, and based on the variety of environmental factors that they all have exposure to, whether we're talking about hormone levels, whether we're talking about a viral exposure, whether there's some type of increased drive that's causing the antibody responses to elevate, those are going to be the culmination of things that are going to allow progression to an autoimmune condition. It's not going to be just that simple genetic concept of here's your genes, here's the disease state. It has to be a combination of things. And I think that this is the message that we as practitioners have to communicate to the patient to get them to understand, because in the media there's definitely conversation sometimes when a headline comes out that new gene associated with X condition, and patients, because they're becoming more savvy and getting their genetic information now, we don't want them to default to, I'm going to end up with this condition, when we know as practitioners that that's not necessarily the case. Some of these mechanisms of action in terms of what allows the progression towards that autoimmune condition, there's a number of things that can begin to happen here. There's a number of ways that these presentations can manifest. One being molecular mimicry here. This is probably one of the more commonly talked about, but that one's simply just looking at the antigen and a tissue in the body have similar structures. They may have similar amino acid strands to where the immune system doesn't differentiate between the two. It reacts against both of these. Epitope spreading. The epitopes are going to be the part of the antigen that's going to be recognized by the immune system, that the B cells and the T cells begin to react against us from what we develop the antibodies. And you get an increase in the spreading as the immune system upregulates. You begin to see that these epitopes, these things that the immune system recognizes that it should develop the reaction to, begins to increase over time. Standard activation, just upregulating the production of B cells here. Viral persistence, depending on maybe different stressors that an individual is predisposed to, there may be suppression of that virus for a period of time, but when a profound stress response occurs, maybe some environment or some lifestyle challenge a person runs into, there's an increase in the reemergence of that virus. It becomes more active because of the inhibition, the suppression of immune response against that, and it begins to proliferate the autoimmune response again. And I think many of us have seen clinically where that can play out. Someone runs into a major life stressor, and then all of a sudden they start having their autoimmune responses flare up again uncontrollably. Polyclonal activation, dysregulation of immune homeostasis here, so there's that general balance. And even looking at considerations for
for innate immunity, not even going to the point of developing a very specific, detailed response against whatever the identified antigen is, but looking at that first line defense from the innate immunity. Those are considerations, and we recognize now that that is part or can be part of how an autoimmune presentation begins to manifest itself. So we don't have to wait until we develop that specific response. This slide is just an illustration. I wanted to put this in here for those that are interested in more detail on how these particular things or how these particular scenarios play out. This is just an example of how that happens. Now, we run into the idea of what's known as TILT, or abbreviated as TILT. And what we're talking about here is going to be toxicant-induced loss of tolerance. And this is many times why we begin to see individuals are having presentations that previously they may not have had. Their toxic burden begins to increase, and as a result of that toxic burden, there's a sort of the straw that breaks the camel's back. You run into a point where there's going to be some antigen, some environmental trigger that the immune system just can't manage anymore, and it begins to have a snowball effect that once that toxicant has set that individual down that road, further progressing them into autoimmunity, there's the dysregulation of the immune system that comes along with that. Then you're going to see that as that immune system is dysregulated, it's more likely to begin to have responses against other antigens that maybe prior to that it had the ability to begin to govern, whereas now it can't. And we can recognize this clinically and maybe even look at it from a statistical standpoint in that we know individuals who have one autoimmune condition have a greater predisposition to have other autoimmune conditions. One of the ones that we probably more commonly see and commonly correlate in clinical practice is that link between celiac disease and Hashimoto's, or looking at the autoimmune response against the thyroid, maybe not even progress to the point of Hashimoto's. So we have to look at there's going to be some toxicant that has to be considered as a part of this process, and that toxicant may be what's pushing that individual overboard. So I say that simply to say that I think in clinical practice a lot of times it's easy to look at food, and food may be the toxicant. It may be what's the primary consideration, but we shouldn't stop just at foods. We also want to consider what other environmental chemical triggers may be having a hand in this as well. This has gotten to the point where now we're looking at it as a cause for disease. It's actually one of the things that is predominantly considered, or when we're talking about autoimmunity, predominantly considered as the driving factor behind the development of the disease. And one of the things that patients always like to know, well, how long is this going to take? And autoimmunity is more of almost, in many ways, more of a management scenario than it is, say, I really hesitate to use the word curative, but because it's really, you're looking at managing an autoimmune condition many times. And patients have to take into consideration what their accumulated level of this toxin is. It's not enough just to remove that individual from that toxicant exposure a lot of times. It really comes down to the fact that if they've built these toxins up in their system, then they're going to have to process these things out. That may come back to looking at the nutrient status. It may be a scenario where they have the inability to conjugate some of these toxins, to run them through the detoxification cycles to eliminate them, transitioning these toxins from a fat-soluble to a water-soluble state. We recognize that many of these toxins are lipid-soluble in nature. They're fat-soluble. So the individual has to understand that it's not just about removing the toxin from the environment, especially if it's chemical, some type of chemical burden or metal burden. It's really about dropping that total burden in the body too, helping them get down what they've accumulated over time. So that's definitely something we have to express to the patients and help them understand as far as setting expectations on a time frame. Now, some of the more common nutrients associated with the immune response and maintaining the regulatory ability of the immune function. You'll see the list here. What I want to do is go ahead and start to tackle each one of these and show you what the literature background is. Autism, there's many considerations you have to make with a condition like autism. This is certainly another one of those conditions. We're not going to look at it and say that there's any one particular causative factor associated here. But I mentioned a little bit earlier with just like we were talking about with RA and the anti-citrullonated proteins, that the anti-myelin basic protein is also a citrullonated protein as well. So it's going to be one of these that when we see that modification of that protein, it's all about, does the patient have the right nutrients in place to prevent them from reacting against that protein, or do they have the nutrients, or is there an absence of the nutrients that's going to allow the immune system to go ahead and have that potential reaction there? DHA has been identified as one of the nutritional cofactors that can help offset that reaction and begins to reduce the response by the immune system that ultimately leads to a reduction in myelin basic protein. I will give you an interesting sidebar on this, and I don't state that there's a correlation here in any way as it relates to autism, but it's an interesting side note, is that I've had some of my female infertility patients that when I start looking for an autoimmune perspective or at an autoimmune looking at their infertility from an autoimmune perspective, that they have an increase in these myelin basic proteins as well. So it's worth, if you work with patients in that realm, it's worth a consideration to investigate that as well. So they may benefit from higher levels of DHA as well. DHA is going to also have other roles, other ways that it governs these responses. One of these is going to be with regards to apoptosis, and apoptosis we probably appreciate most from our learning about it as it relates to oncology and ridding the body of these aberrant cells and having adequate responses against these. DHA does the same thing here. When you look at, for example, when we talk about the interaction of mercury here, mercury is going to have a alteration in the structure of the lymphocytes and the way that the lymphocytes physiologically act, and that interference of mercury, while mercury being in and of itself a heavy metal and a toxic burden, it may be the impact that mercury has on the physiology of the lymphocyte, and recognizing that a lymphocyte as an aberrant tissue that needs to be eradicated out of the system, that may be where DHA comes into play here. One of the things we want to consider on this is that these cells can be, again, they can be overreactive at times, and sometimes just as a part of cellular physiology, we get an uncharacteristic response from cells, not something that we find typical. It's not necessarily a pathogenic or a disease-oriented response from this cell, but over or sort of gun-ho lymphocytes may become overreactive against that. So we want these cells cleared out. We want that apoptotic effect in place so that we can remove these cells both from an immune standpoint but also from a structural standpoint, so that cell, that aberrant cell, doesn't become an antigen to allow the immune system to begin to develop a response against that. Just another correlation here, looking at this again all the way down to the genetic linkage in this. This is looking at islet autoimmunity. And we recognize that there's an interaction between how the omega-3s interact with the genes and control the desaturase enzymes here. So just another link in this. And again, you have to make consideration too for the various aspects of autoimmunity and looking at how individuals with regards to, like, for example, the islet immunity, how the damage of the cells from the chronic inflammatory response, how that sets up a condition or a state where you don't have adequate vitamin D. Lack of vitamin D is going to potentiate the autoimmune activity. So there's a number of factors that have to be considered, and just having these nutritional cofactors in place may better govern how these T regulatory cells interact to prevent that further progression. You can see here inverse association between the omega-3s and the anti-citrulated proteins. And interestingly in this is looking at protect against the development. So when we talk about nutrients having a predictive role here, this is an example of that predictive role. They may protect against the further development of the RA. So not just waiting until the disease onset. So really what it boils down to, you're looking at modulating the Th1 and Th2 subset. The T regulatory cells are going to have the greatest amount of impact on that, and that appears to be what the, not the only mechanism by any means, but that appears to be certainly a mechanism by which the omega-3s interact. And then you get reduction of the Th17. The Th17 is well associated as one of the lymphocyte subsets, the T lymphocyte subsets, as well as the production of interleukin-17 that drives the autoimmune response. So certainly we want to regulate that group of cells, of T cells. The polyphenols have such a profound effect on so many areas. You can see here when we're talking about EGCg, the epigallocatechin gallate, you're really looking at green tea, and this is one of the ones that is probably, I tend to think about the sort of the big four, which we'll detail here in a moment. But green tea is going to have such a profound effect in supporting immune tolerance and suppressing the overreactivity of these Th1 cells and preventing them from driving that progression towards that autoimmune predisposition. And you can see here this particular study notes it as an epigenetic mechanism. Now, looking at some of the additional factors here, dysregulated T cell function with respect to different subsets of T4 critical. And look at this in the development of the autoimmune inflammatory process. So we know that the T cells have a role here, very well established fact on this. But when you look at the EGCg is going to be a determinant in how these T subsets differentiate. Do they differentiate into T cells that are going to drive the immune response, or do they differentiate into T cells that are not going to be proliferative in favor of autoimmunity and that increased inflammatory connection with that? Another mechanism here by which the polyphenols act, the SIRT1 is going to be one that's gotten a lot of attention, but the polyphenols are going to have a regulatory effect in this as well. Just looking at we know increases in inflammation modifies tissue structure, so that would have the potential to increase neoantigen responses and also to act as a proliferator of the various T cell responses that are autoimmune oriented. And then reduction of, or potentially alteration of apoptosis. A few slides back we mentioned how apoptosis is essential in being able to clear out these aberrant cells that don't need to be there, but also clearing out the lymphocytes or the lymphocytes that don't need to be there either. So we want to make sure that apoptosis is in place and working efficiently. Now, the way that this can be seen with the micronutrient test is probably best seen through the Spectrox marker, where you're looking at total antioxidant function. A lot of times the colorful aspect, and this is actually something you can ask patients when you start talking about the colorful components in the diet, looking at the various polyphenols that are found in all the real bright, colorful foods. Those antioxidants that are there, those are often not in high percentages in many diets. And then certainly the ones that we can appreciate from other aspects of the diet, where it be something like teas or whether it be the spices and herbs that are used. These are all going to be a lot of times deficient in the diet, and those are going to be very contributive to the low Spectrox level. So part of increasing Spectrox is not just increasing the individual antioxidants that someone has, while that is important, but it's also about increasing or decreasing their total oxidative burden by increasing the number of polyphenols that they have exposure to. Sort of the big four, your resveratrol, curcumin, quercetin, the catechins, these are ones that probably have the greatest amount of evidence behind them in terms of the largest number of studies to support their utilization. So these should be on the top of your list for consideration for not only autoimmune intervention, but just in scenarios where you need to increase the Spectrox level and reduce inflammation in coordination with that. Vitamin D is recognized in really a large number of autoimmune conditions. It's a pretty expansive list, the number of conditions for autoimmune conditions for which you'll find vitamin D connected. But same thing that we were talking about with the omega-3s and looking at the T cells, the vitamin D has an impact on the regulation of the regulatory T cells. So those regulatory T cells need to be in place. They need to be working efficiently to govern which T subsets they're going to promote production of. And without vitamin D, that doesn't happen efficiently. Just as an example of showing you how this, looking at cardiovascular disease, and maybe we think about cardiovascular disease here from the standpoint of an autoimmune, looking at one of the disease theories on that being autoimmune driven, you can see that vitamin D has numerous mechanisms through which it can act here. It can have an endocrine response where it's affecting distant tissues throughout the body. It can have more of what we typically classify as a paracrine response, where it's having a very local effect throughout the body, or a local effect within a certain region of the body. And it even has an autocrine effect where we're looking at the production of or the utilization of vitamin D having an endogenous effect within that cell in terms of how that cell or how that lymphocyte has a reaction to whatever potential antigenic exposure that it has. And then also looking at, as a result of that, the modulation of the inflammation. The worse the inflammation becomes, the further the progression of the autoimmunity typically is carried forward. So the vitamin D is going to be real important with upregulating the T cells, with downregulating the presentation of the antigens through the antigen-presenting cells, and then just modulating those T helper 1 and 2 subsets. Vitamin A, you can see there's a lot of nutrients that are having the same impact here in terms of what they're doing. Inhibits the expansion of the dendritic cells. We haven't really talked about dendritic cells up to this point. Dendritic cells are going to be, you can think about those as being like samplers to the environment. They're more or less sort of checking the environment, giving information back to the immune system in terms of how it needs to react. So vitamin A prevents the overreaction, the overcommunication by the immune cells or by the dendritic cells back to the rest of the immune system to be responsive. It also has effects, like I mentioned a little bit earlier, on the Th17. That Th17 and the upregulation of interleukin-17 as a part of that is very well known to drive the autoimmune response. One of the ways in which it does that is through the increased production of inducible nitric oxide. So that's one of our inflammatory mediated, or the inflammatory mediated aspect of nitric oxide. Asparagine, I mentioned very early on that I would give you a novel marker relative to the micronutrient test. Asparagine is what I was referencing here. And asparagine, very classically seen, and I'll show you an example of this coming up, but it's very classically seen with autoimmune conditions for patients that are maybe expressing autoimmune thyroid antibodies or antibodies to other tissues. Asparagine is maybe an indicator that person, it can be very predictive in terms of, for us as clinicians, thinking about where we want to take our mindset of how we're going to approach a patient. Maybe our mindset needs to be autoimmune when we see asparagine. And the mechanism by which that begins to happen is that we produce these, or we have glycans in the body, and we can think about these as being maybe better stated as a glycoprotein or a glycolipid, so where you're binding a carbohydrate in a protein, or a carbohydrate in a fat. Well, when we make these chains of protein or of sugars here, the glycans, asparagine is one of the ones that, or is one of the amino acids that's placed on top of that, and it has a regulatory capacity to it, but in a state where someone has a deficiency in asparagine, that glycan is misformed, and these glycans are formed in the endoplasmic reticulum, is where you're going to find them as far as where they're going to be formed in the cells, and they go out and they have communicative ability. So if you don't attach asparagine to that glycan, you provide the wrong message to other structures in the body, and you maybe insert that, for example, maybe you insert that glycan into a structural component, and the immune system looks at that and it says that is a foreign substance. That looks more like what I might see from a lower level eukaryote or prokaryote. So maybe there's more of a microorganism type of presentation of this. And the immune system knows that those things are problematic. Those are things that inherently are not, they're foreign substances to the body. They're not going to be inherently found, and they need to be eradicated. So therefore, because of that lack of asparagine, because it changed the structural profile of that cell, then the immune system reacts to it, whereas otherwise if asparagine would have been there, that wouldn't have necessarily taken place. Now, one of the reasons that we can see a deficiency in asparagine is because of glutamine. The combination of aspartate and glutamine through the action of the asparaginase or through the action of asparagine synthase ultimately gives us asparagine. So if we're utilizing up glutamine levels at a rapid rate, that's going to further increase our likelihood of having an asparagine deficiency as well. So asparagine is a novel marker you want to consider. Selenium. Selenium is one that is utilized for autoimmune thyroid conditions. There's other mechanisms by which it can benefit these patients as well. But selenium is one that you're going to see that you'll want to consider. So, for example, if you see a low selenium, a low asparagine, and the patient's expressing some type of thyroid presentation or symptoms associated with that, maybe consider that that might be an autoimmune presentation that you might really be looking at there. Some of the other mechanisms here you can see it suppresses cytokine excretion. It's going to have regulatory ability on the T cells, prevents apoptosis from those follicular cells, so prevents them from breaking down and being further antigens towards the immune system. Protection from thyroiditis, so again, just reduction of the inflammatory responses here. And it just makes them more resilient at the end of the day. The availability of selenium, it just adds, it just solidifies those cells of the thyroid to make them more resilient against immune responses. So there's a number of mechanisms by which selenium can play a role here. So certainly make a consideration for that in your autoimmune patients with thyroid concerns. Your role by which it's necessary to maintain your selenoenzymes is going to be between 60 and 75 micrograms a day. Keep in mind that that's not going to be a level sufficient for repletion of someone in a deficient state. You're going to need to be up around 200 on that, maybe even a little more in some scenarios, and you're going to want to watch your balance with vitamin E there as well. You can see in this particular list of the enzymes here, the glutathione peroxidase, so being able to maintain the activity of glutathione, recycling glutathione. Selenium becomes important for that, and then of course many of us recognize our deiodinase enzymes for making sure that we're converting between T4 and T3. Glutathione there's a link here obviously to selenium, so it's very common to see low glutathione levels with low selenium as a part of that, and again the relationship there is going to be in part related to glutathione peroxidase. But the thing you want to note with glutathione is that glutathione is a pretty good marker just to give you a baseline idea of how efficient the immune system is. If that marker is low, then you're going to see that that the person is likely going to have a low immunodex associated with that, just overall capacity for immune function. And very characteristic is that you'll see that there's going to be a low glutathione, and often you'll see low spectrox levels linked to that. And keep in mind when we talk about the application of this test, we're talking about looking at the T lymphocytes in terms of the tissue you're actually assessing the nutrients within. And what I found personally early on is that the more benefit I could provide the patient in terms of delivering antioxidants, whether they were nutrient-based or plant-based, that were going to reduce the oxidative burden and raise the spectrox and raise the glutathione levels, interestingly enough, it seemed to raise the other nutrients at a faster rate as well. And what you see when that all begins to happen is that not only does glutathione come up, but the the immunodex level comes up too. So you're getting an overall gauge of how well those lymphocytes can respond to the mitogen and how well they can proliferate themselves under some degree of immune system challenge. So glutathione is definitely one you want to keep an eye on and get that one back up, given that it's going to be illustrative of persistent oxidation when it's low. Now, as it relates to autoimmune conditions here specifically, we're looking at the impact that the glutathione has on the complement system as a potential role. Like the vitamin D, like the omegas, it also has capacity to influence the T regulatory cells. But as it relates to the complement system, keep in mind that complement system is simply that. It's a complement to your antibodies and to these phagocytic cells that are engulfing these antigens and these pathogens and trying to eliminate these pathogens out of the body. And the end result of this is that complement system it's going to be an upregulation effect, so it can begin to get out of control. Well, glutathione is part of what has that inhibitory role as a checks and balance to prevent the complement system from being too reactive, from being overreactive, as we mentioned with some of the mechanisms by which autoimmunity can begin to happen. Another mechanism here, looking at how it's illustrated in a couple of other autoimmune disease states like SLE, RA here. You can see I mentioned a little bit earlier the T-cell function role here. Really what you're looking at with this is that a lot of this is going back to the inducible nitric oxide, and you're down-regulating that inducible nitric oxide that is going to thus in turn drive nitric oxide production, which may damage the DNA, may damage some of the other structural proteins throughout the body, by which the immune system would then recognize those as foreign tissues, as antigenic tissues that it needs to develop a response against, versus a tissue that is a normal self-tissue that should not be a problem. So just another mechanism by which that occurs in terms of driving the inflammation. Zinc is going to have a role. Many of us recognize zinc when it relates to blood sugar regulation as being the structural element by which we build insulin around. We know that there are several components within the glycemic physiology where we can have an antibody response or an autoimmune response. We can have it against the insulin. We can have it against the GAD enzyme. We can have it against the islet cells. And then also one of the ones that is probably least talked about are these zinc transporters. Ultimately, if you're looking at the beta cells being able to build insulin, they've got to get that zinc into the beta cell to be able to build that insulin molecule. And we can develop antibodies against these zinc transporters that allow us for the uptake of zinc to in turn thus build that insulin molecule. And this is one of the proposed mechanisms on the likelihood for the development of progression of type 1, and also one of the reasons that we probably more now see that type 1 is not necessarily a juvenile condition, but that individuals develop that later in life. And it just goes back to a lot of the earlier points made that with the toxic accumulation or the total burden of accumulation of toxins, there's going to be a point at which you cross the threshold by which the immune system can hang on and it starts to react. Just looking at how these might play out on the micronutrient test, a low oleic acid may indicate low omega-3 status. Vitamin D intracellularly certainly can be a role here. The low glutathione, these are all going to be factors that you can just, and even with the asparagine, you could add that in here too. But these three that are listed, the oleic acid, the vitamin D, the glutathione, you can just real quickly look at those and say that person's probably losing T regulatory cell capacity and increasing the predisposition towards autoimmunity. Now, we all like to see case studies in this, so what I want to do is just give you one case study on this. And what you're looking at here, 28-year-old female, miscarriages. So right away with the miscarriages, you may be thinking about DNA methylation as a consideration on this. She had a history of Hashimoto's here. She had gone through using Synthroid. She had even used Armor in this for a little while, not very long, but she didn't really notice any significant modifications with those. And what really drove her in to ultimately present as a patient was the fact that she had developed hives, and the hives were really just to the point of being unbearable with her, and they were further, when she went to traditional treatment on this and looked at topical steroids, she gained a significant amount of weight here. And there was already some anthropometric challenges anyway with this patient, and then she took gluten out of her diet, or took it out for a little while, but didn't take it out completely. Well, know what the presentation was for this patient. You see her antibodies. She had both thyroid antibodies elevated here, and very true to the body of evidence that we presented up to this point. Asparagine's there, so we know we've got some aberrant tissue that the immune system is recognizing. We've got vitamin D, so we've lost control with the T regulatory cells. We've got glutathione present, same thing, plus we're not controlling inflammatory cascades, and there's an upregulation of nitric oxide. And then, like I had mentioned earlier, when glutathione is low, Spectrox is typically low as well with that. So we see that there, just from a nutritional standpoint, this patient, in terms of being able to modulate the environmental interactions that she's having, this patient doesn't have the capacity to do that. So even in terms of, and like I mentioned with the anthropometric challenges, she's probably got some buildup of various toxicants in her system, given that those are lipid-soluble, usually lipid-soluble molecules. So nutrition is going to have a very profound effect in just, one, helping this patient modulate the symptoms, but two, this patient's probably looking at a little bit of road ahead of them to reduce the burden in the body of these various toxins, and during that time frame, we've got to help them modulate the immune system, and controlling these nutrients is how we're going to go about, part of the way we're going to go about doing that. Gut dysbiosis, so let's dovetail into this. I think this is probably, again, for most of us in terms of the triad, this is probably the easiest one for most of us to connect. I don't think the link between these two is all that difficult for us to make here. So with that said, look at a couple of things here. Let me give you one mechanism. This is by no means the only mechanism associated with this, but it is a mechanism nonetheless. So when we talk about the consumption of food, I always like to make mention to the patient that food is not inert. Food is either working for you or working against you. So if someone is taking in, for just simplicity of terminology here, unhealthy food that aren't going to have the polyphenols in there that are going to be modulatory to the ratios of bacteria, to the type of bacteria that tend to predominate in the gastrointestinal environment, if they're not taking in forms of undigestible fiber that are, one, going to promote bowel motility, prevent the buildup of a more acidic environment, reduction of the pH, you're also looking at the lack of consumption of those foods is also going to decrease the undigestible fiber, by which many of the bacteria are going to take and use as a fermentable source to then in turn make short-chain fatty acids, the most important or most recognized of which is probably butyrate. Butyrate is going to be essential in helping to maintain the integrity of the enterocytes. One of the things that we do with butyrate is it's a fuel source. Think about it much like glutamine. The enterocytes, they like glutamine, they like short-chain fatty acids, and they're going to use those two things as a fuel source. And if we don't have the right bacterial makeup, if we don't have the right component of foods, specifically in this case undigested fermentable fiber, then there's going to be an increase in the there's going to be a decrease in the production of these short-chain fatty acids, and thereby when we look at a group of cells that are replicating themselves anywhere from every 3 to 9 days, that's a pretty fast turnover cycle. So we need to be able to provide those cells with quick, efficient, consistent fuel sources so they can carry out that replication process. Now, some of the various foods that are going to help carry that out, you'll see in here leeks, asparagus, chicory root, Jerusalem artichoke. These are some of the ones I think most of us would probably stay away from: wheat, oats, and soybeans, just given the allergy connection there, or the immune reaction, not necessarily just allergy per se, but the immune reaction associated with those. But again, the more saturated the fiber component in the diet, the less the predisposition towards dysbiosis. So, the question therefore then arises, well, can we make nutrient associations with that? And we can do it at a macronutrient level and at a micronutrient level and at a macronutrient level. And what you'll see is that when individuals are consuming diets higher in protein, higher in fat, bacteroids are going to be a higher, more predominant species. If you're doing testing that differentiates these, if you see an increase in Prevotella species, that's probably an indication that that individual is consuming too much carbohydrate in their diet. They need to modify the overall intake. And if the Lactobacillus and Bifidobacter strains are not there, again, you have to ask the question of how much fiber is this individual consuming? Are they really eating a diet that is complementary to their gastrointestinal tract? And the answer may indeed be no on this. Now, as we approach the end here, what I want you to see is that there's been some significant changes which all of us probably recognize, and all of us probably emphasize to our patient, and indeed if we don't, we absolutely should, in terms of the impact that food has on the environment of the gastrointestinal tract. And you can see not eating seasonally, eating manufactured, so to say, meats versus wild meats, eating in industry meats, if you will, maybe a better way to say that. New strains of grains, all these genetically modified crops. Looking at that list, that's a pretty expansive list that a lot of people eat. The applications, as I mentioned earlier, with these various toxicants that get applied directly to the food, and these things accumulate in the body. Artificial flavorings and preservatives. You know, a lot of times you pick up a boxed food, most of the ingredients in there, you're sort of scratching your head as to how these things even get considered as food. And then looking at just simply, what do we put food in? Are we putting it in ceramic and glass, or are we putting it in a substance where we may get leaching of that particular material into the food, and then ultimately storing that material in our tissues as well, that could ultimately become a toxicant. And again, with something like this, you have to ask the question, how long has that been going on? Is that something that's been a lifetime trait for a patient? And if it is, that bioaccumulation may be at a greater level than someone who has very intermittently done that. So those are questions we have to ask as well. This particular illustration is just going through sort of reiterating some of the previous points, but it illustrates the diversity in how the probiotics interact with the gut. They're not just microorganisms hanging out. They're having very direct impact on modulation of the immune function, what they're supplying to the enterocytes to maintain the integrity of those tight junctions, to make sure that zonulin and occludin are interacting like there should be, to prevent that closing and opening, if you will, of the tight junctions, and then also having their own impact on other microbes in the environment that may be disruptive to these states, and that may act as a progressor of the dysregulation of the T regulatory cells, and may act as a promoter of further progression of just simply an inflammatory response. So there's numerous mechanisms by which the probiotics can have a role here. Now, what you want to look at if you're looking at the micronutrient test, a pattern that you're going to see very consistent to there not being enough probiotics, to there being some degree of dysbiosis, is going to be this B vitamin category. If the larger percentage of these B vitamins are low, you have to begin to think about that there's some level of dysbiosis that's at play here. Maybe you've got an overgrowth of a potentially pathogenic bacterial or fungal strain, or maybe there's just an absence of some of the lactobacillus strains that are going to be or that are going to be producing some of these B vitamins. The ones that are most commonly recognized, again, as illustrated here in this study, the B vitamins, vitamin K. Roughly half of our vitamin K is produced by our probiotics, so therefore if we see low vitamin K, it should be at least some consideration made to the fact that those probiotic colonies may be inefficient, and we may need to do something to boost those colonies, whether it's direct supplementation of the probiotics, or whether it's looking at increasing some of the dietary components that are going to enhance the growth, enhance the proliferation of these probiotics as well, and maybe just taking things out that are suppressing some of their activity. So the ones you want to consider right off the bat: B12, folate, B2. So those are your main B vitamins you're going to see with this. But again, the pattern you want to look for in this is that if the majority of the B vitamins are low, think dysbiosis. Think that I need to ask some more questions. I need to look at some other markers, maybe the vitamin K, maybe the glutamine levels, to give you an overall perspective on gastrointestinal function. But then, is there consideration for autoimmunity? Should I be looking at D and glutathione and vitamin A and asparagine here? That may even further illustrate what's occurring with that individual. So in closing, and thinking about looking at each aspect, each point of this triad here, looking at the genes, looking at the epigenetics, looking at the gut dysbiosis, what we as clinicians from a societal perspective have to keep in mind is that autoimmunity is increasing. The factors that drive autoimmunity is increasing. Not just when I say environment, not just the environmental antigen itself, but the environment that our patients live in that influence the foods that they consume and the effects that has on the gut. Those are all factors that we have to consider, and that are likely going to continue to worsen the overall autoimmune state in the society at large, and the number of autoimmune patients we're probably going to be seeing. Keep in mind that there's, as illustrated through the presentation, that there's not one sole cause for autoimmunity. I think that's